Full. Thank you. So the WHRI would like to acknowledge that we are uninvited guests on the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. As a provincial research institute committed to improving the health outcomes of women, including those across the 2S LGBTQIA+ spectrum, we recognize our responsibility in the collective effort towards establishing culturally safe healthcare systems and services that address health inequities among Indigenous peoples, especially Indigenous women, girls, and Two-Spirit peoples. And we encourage all people involved in research to read both the Truth and Reconciliation Commission of Canada Calls to Action and the In Plain Sight report and reflect on the ways that we can incorporate those recommendations into our work. So as we gather in spaces together, we encourage you to reflect on your positionality on these lands and your personal commitments to reconciliation. So with that, I'm very pleased to be able to introduce our round speakers for today. Reetinder Kaur is a Punjabi language instructor at Simon Fraser University and a PhD candidate enrolled in the UBC Interdisciplinary Studies graduate program and recipient of the prestigious Kidney Research Scientist Core Education and National Training Fellowship, which trains future leaders in kidney research across Canada. She completed her master's in anthropology, Asian studies, and a PhD in anthropology. She has over 10 years of experience in qualitative health research, project coordination, and teaching in both Canada and India. Her research interests include South Asian health, organ donation and transplantation among racialized communities, and gender disparities in living kidney donation. She has also served as a consultant on various Punjabi language translation projects in the past. Moving on to Jessie Lehail, is an award-winning social impact and communications leader dedicated to women's advocacy and health equity, one of our favorite types of people. As CEO of the Kaur Collective Foundation, she empowers Sikh women globally, focusing on storytelling, faith, health, and food security. Jessie's groundbreaking work includes co-creating the Bridging Language and Health, a gender-sensitive translation framework for Punjabi women's health education. She serves as a research coordinator with Dr. Lesa Dawson, investigating cultural influences on South Asian women's decisions regarding hereditary ovarian cancer testing. As Vancouver chapter director for Shelter Movers, Jessie leads efforts to provide free moving services to survivors of gender-based violence. She also serves on the board of directors at Fraser Health Authority, contributing to overseeing a $13 billion budget and co-leading initiatives to address systemic racism. With over 15 years experience in advancing women's advocacy, Jessie is also a professional contemporary abstract painter. Very interesting. And then we have Dr. Lesa Dawson, a gynecologic oncologist with more than 20 years of experience caring for women diagnosed or at risk of gynecologic cancer. She runs the VGH Gynecologic Cancer Prevention and Survivorship Clinic, which serves women across BC. Her patients include both women who have gynecologic cancer and those who have hereditary dispositions such as BRCA, or RAD51C/D, and Lynch syndrome. She has training in obstetrics, gynecology, oncology, cancer genetics, clinical epidemiology, and menopause. And her current research is focused on cancer survivorship, equity in women's health, and population-based testing for hereditary cancer predisposition. She is dedicated to the delivery of personalized care for high-risk women and management of cancer risk and premature menopause. She has funding from SSHRC, MSRF, and CIHR. So with that, I will turn the floor over to our speakers.
Thanks, Catherine. We're pleased to get started. I think, Catherine, I have like 2 or 3 slides we'd like to start with, and then I'll hand it over to Jessie and Reetinder. Can you everybody hear me and see me okay?
We can hear you. Yep, looks good.
Okay, I'm pleased to hear that. So I have to say that now that you've heard the introductions for Jessie and Reetinder, you can see how absolutely privileged and grateful I am to get to work with them both, these super talented people and dedicated people. And so I'm really not the center of this talk in the least. I do want to just give people a little bit of background before you hear from them, which is to tell you how we as a team got interested in this question and how how the work that they're about to describe is so super relevant in many, many domains of women's health. In my particular case, I came to this interest kind of in a sideways way, in the sense that, oops, there you go. I want to show you this. Because I work, as Catherine said, in hereditary cancer, and we were looking at some data from the hereditary cancer program, and something just jumped off the page at me in the draft of a paper, which is that the percentage of people who were women who were being seen at the hereditary cancer program was really, really low compared to what was the population at that time in British Columbia. And this was about 2018. And although at that moment, 8% of the population were South Asian, only 3% of the people that were coming to the hereditary cancer program for genetic testing were South Asian. And that out of the gate was something. But then when we got even more deep into it, what we saw is that if people who were non-European, and this translates to lots of issues, but in particular with this, what we saw is that people who were Asian and people who were South Asian, if they did make it to testing, in fact, had more than a double risk of finding a hereditary predisposition, and double, triple almost, the chance of finding an inconclusive result. And the reason that is so important is because we are providing the wrong care, often at the wrong time, and putting up a lot of barriers to many communities across Canada. And I'll give you an example. If you were to take two women, same age, 42, both are immigrants, one's from Punjab and one's from Ukraine, you will find that their healthcare, in fact, is really not equal. And there's a lot of reasons for that, one of which, of course, is culture. There's a lot of beliefs and different ways to interpret healthcare, interpret need, interpret stigma in cancer, particularly in various communities. But there's another issue, which is communication. And this is really where I came to know and love Reetinder and Jessie, is when we started digging into this and we were able to blow the dust off an old hereditary cancer program consent form. And I showed it to some various people and spoke to a lot of healthcare professionals. The theme that I kept hearing over and over was, yeah, I actually speak Punjabi, or I actually speak Hindi, or whatever language. And I know when the translator is speaking to my patient, I think, that's not what I said. Or in the case of genetics, it's particularly fraught if you see a family member who's translating for somebody on a genetics risk. So this is how we came to this story. And I think the point that we want to make, the three of us, as you get into the talk today, is to say that we need to step back a little bit and distinguish translation from meaning, and make sure that when we are trying to communicate with our patients, whatever the topic, I've picked hereditary cancer, but whatever the topic, we need to really be thoughtful, and we need to be sure that we're providing people with information that is, sure, translatable, but is meaningful, that is culturally appropriate, and makes sense to them and empowers them to make their own healthcare decisions. And with that, I'll hand it over to the experts, and thank everyone for coming, and thank WHRI, Catherine, Laurie, and I see that Dr. Arun Garg is here, who's the president of the Canada India Network Society. I will remind everybody that we are having a conference through CINS in June of 2026, and I'll stay tuned. We'll be promoting that down the line, and there will be quite a lot of content about women's health then. Talk soon.
Wonderful. Thank you so much, Dr. Dawson, for championing our work and for creating this wonderful opportunity for us. So as noted, I'm Jessie Kaur Lehail. Reetinder is here as well, but I'll start off today. So today we're really inviting you to see what most overlook, the invisible barriers that Punjabi women face in accessing health information. This work is really not just about language. It's about making the invisible visible. It's about giving Punjabi women the language and the power to ask questions, make decisions, and advocate for themselves. So today our presentation is called Transforming Punjabi Women's Health Through a Culturally Safe Translation Framework. And this isn't just a title, it's really a call to action. For too long, translation has been treated as a technical task, a simple matter of converting English to Punjabi. But what's truly at stake is the voice agency, and access. And when translation fails, Punjabi women are left out of conversations about their own bodies and their health. Our framework is about more than words. It's about giving Punjabi women the power to name, to question, and to decide for themselves. Reetinder, next slide, please. So disclosures, we want to be transparent about our position and our motivations. As you see on the slide, we work within this academic and research framework, but we also provide translation services to organizations on a cost recovery basis. And this is truly a response to urgent unmet needs. We have discovered this problem and are actively and quickly working to meet this unmet need. That being said, we are seeking funding for this work, and we recently applied for a $300,000 CERC grant and also additionally a $100,000 Shoppers Drug Mart grant. We were sadly unsuccessful with the CERC grant, but we will apply again. The Shoppers grant has not been announced yet, so we're fingers crossed, making hopeful that we'll get that funding. Truly, though, this point of sharing is that we are persistently seeking funding because the stakes are too high to stop. Our commitment is not contingent on funding. It's really driven by the reality that everyday Punjabi women need access to health information that could change or even save their lives. Next slide, please. So our learning objectives for today really want to ground ourselves in what we hope you'll take away from today as outlined on this slide. First, we want to identify the linguistic and cultural challenges in translating women's health materials into Punjabi. This includes the gendered nature of the language, the existence of multiple scripts, and the deep sensitivities around women's health topics. Second, we're really inviting you to understand the features of a gender-sensitive translation framework, one that doesn't just translate, but transforms by centering women's realities. And third, we will discuss the critical role of community engagement, anatomy comprehension exercises, and feedback sessions that are not afterthoughts, but really are essential to creating resources that are accurate, relevant, and empowering. Next slide, please. So defining the term Punjabi. Punjabi is not a monolith. As the slide says, Punjabi refers to anyone with origins in undivided Punjab pre-1947 or present-day India or Pakistani Punjab. But this is not just a geographical marker. It's a complex living identity. It encompasses a diaspora shaped by migration, faith, language, and resilience. And when we talk about Punjabi women, we are talking about a tapestry of experiences. Our framework is designed to honor this diversity, ensuring that the resources we create are not one size fits all, but responsive to the true complexity of our community. Next slide, please. So you may be wondering why Punjabi language is important in Canada and BC, especially with the current climate in the health sector and all the complex problems and solutions that are out there. But really, we're looking at numbers, and the numbers on this slide are striking. Punjabi is the most spoken South Asian language in Canada and BC. It's spoken by 5% of BC's population and by nearly a quarter of residents in Surrey and Abbotsford. We're also using data from 2021, and we know that there is, in the last 4 to 5 years, there has been a dramatic spike in the amount of Punjabi people and language that's spoken in the area. So we feel this number is actually not true representation of the reality of the population. But behind these stories, behind these numbers are stories of silence. Many Punjabi women, sadly, cannot read in any script, and many rely on family, often male relatives, to translate sensitive health information. This is not just a language issue. It is a question of autonomy, privacy, and dignity, and our work is about making sure that these women are no longer invisible in the health system. Next slide, please. So Punjabi translation framework for women's health. This is really our work in progress. As you see here and are hearing from us, our framework begins with asking relevant targeted questions of translators. This is not a mechanical process. We are really trying to challenge translators to consider who is their audience, what are their realities, what cultural and gender nuances must they navigate. And we are developing a process that is iterative and reflective and not static. Our goal is to ensure that every translation is not just technically correct, but meaningful, accessible, and empowering for Punjabi women. Next slide, please. So we are today doing this presentation for the WHRI, which we're so excited about. But we really looked into the newly published 2025 to 2028 strategic plan, and our work is deeply aligned with the Women's Health Research Institute plan, as highlighted in these slides. So we are focusing on 3 of the 5 priorities that were outlined in the plan by fostering an inclusive culture of research and evidence, by promoting cultural safety and collaboration. With this framework, we're empowering women's and newborn health research community by providing tools and resources to close knowledge gaps, to make research accessible, not just excellent. We build meaningful reciprocal partnerships, with communities, clinicians, and researchers, which is the 3rd pillar or value that we are connecting with. So really, our framework is a living example of these goals in action. We're not just talking about equity, impact, and excellence. We are enacting them, making sure that research truly reaches and serves Punjabi women. Next slide, please. So why do we need this framework? This slide asks a vital question, and the answer is simple: because health information is complex and clear communication is essential. Language barriers, miscommunication, and literal translations, perhaps even reliance on AI now, are missing cultural context and are really all conspiring to keep Punjabi women on the margins. Translated materials can improve, and I should say culturally competent translated materials improve access, but only if they're created with an understanding of gender and family dynamics and a commitment to cultural appropriateness. Our framework is about ensuring that health information is not just available, but really truly accessible and empowering. Okay, next slide. So Punjabi language considerations. As the slide outlines, Punjabi, again, is not a monolith. There is script variations. So there is 2 scripts, Gurmukhi used by Sikhs and Shamukhi used by individuals living in Pakistan. There are also 3 major linguistic zones, each with significant variations. Many Punjabi women, especially elders or those from rural backgrounds, may not be literate in any script, and audio resources become essential. Medical terms are often unfamiliar. Even basic anatomy can be unknown. And the translator is a gatekeeper. And our framework is about making sure that gate is open so every Punjabi woman, regardless of literacy or background, can access and understand health information. I'm going to turn it over to my good friend Reetinder to carry on with some of the slides. Thank you.
Reetinder, I think you're muted.
Sorry. Thank you, Jessie. Hi, everyone. So I'll be sharing and beginning my presentation from some of the Punjabi language considerations that we are proposing. So as Jessie mentioned, that there are 2 scripts of Punjabi language which are often overlooked in our translated work that we often see. So most of the translated documents in Punjabi are in Gurmukhi script. So I'll also talk about and give some examples how this could exclude a certain population who are Punjabi speaking, but they don't read this particular script of Punjabi language. As Jessie has already mentioned that, Gurmukhi script is read and written and written by a Sikh population, because one of the important examples is Sikh scriptures are written in Gurmukhi, and Sikhs are also highly represented among South Asians in terms of religion. And if we look at certain populations like Surrey and Abbotsford, 26 to 27% of population is reported to be Sikhs in census. So this is an important demographic, but also making sure that other religions, for example, Muslims from Pakistani, Punjab, they are also, they have access to this population, to the translated materials as well. Just to show you a little bit of idea of when I talk about, Indian Punjab and Punjab in Pakistan, what do I mean? So in 1947, Punjab was divided along with division of Indian subcontinent. So as you can see, so largely the immigration, when we say Punjabi immigration, is from Indian Punjab, but also significant immigration of Punjabis from Punjab in Pakistan. Both speak Punjabi. As Jessie has already mentioned, a lot of linguistic variations. So three are major linguistic variations, which means that there are different terminology, vocabulary used in these linguistic zones, which are geographically located. So it is very important for translators to consider that there are, so if they're using one term or one word for something in English, it may not be understood by somebody who is from a different linguistic zone. So they need to use the words that are more common amongst all linguistic zones. Now, thinking about what if we don't really produce paper copies or written translated materials? What about audio resources? So audio resources are great. That addresses script variation issue. It also improves accessibility. So I'm using this as one of the examples. So this is cervix self screening video in Punjabi. So it is good. So as I have already talked about, like it really addresses the script variation and improve accessibility for women. But one of the words that it uses for cervix, which is yoni, that is not commonly used. So that was really surprising to me that they have used this word for cervix. So this is about cervix screening. So this is really important thing that we have to note. Many Punjabi women may lack comprehension and understanding of their body parts. So it is also important to improve accessibility, that we use the terms or add explanations which are easily understandable to Punjabi women. So as we think about translations, we are not thinking about somebody who is fluent in speaking a language. We are talking about somebody who's able to read the translated materials, because we are producing a lot of educational materials, patient education materials written in Punjabi Gurmukhi script. As Jessie has already kind of touched on it, that we are producing these materials for Punjabi immigrant women who came from rural backgrounds. We need to consider their literacy rates and their understandability. So this is one of the examples. Now I looked at another document that is produced by same organization that used a different explanation for cervix. They use Bachchadani da Muh, which is a commonly used explanation in by the Punjabi women. So it is also important to use consistent language in translated materials. So we have different documents using different explanation or translation for cervix. So I use cervix as an example. And I also noted that a lot of women's health translated materials, they use a lot of English words. Every time translators are not able to, understand a term, they use and translate it as it is in English. So there was this word like pessary, and here it is in English. So I was like, what it is? Because for somebody, given our target population, is it really understandable what this really means if there is no explanation added here? The other important consideration is that Punjabi is a gendered language. From its sentence structure to grammar, things are assigned gender. Gender roles play a very important role in how gender is assigned in certain, terms. So I'm noting a lot of, issues with assigning gender in our translation. So Jessie and I were looking into AI. How do Google Translate, translate certain things, or Chat GPT translate? So I put something like, I'm translating this document. So now Google Translate doesn't understand that Punjabi is a gendered language. So they give us default masculine. So I give a hint to Google Translate that I'm a female, then they do it right, but then they, additionally also translate for female in the bracket. Similarly, ChatGPT is also default masculine. So how do translators who are using AI, who are not really fluent in the language, but they're depending on AI to produce translated work, how do we navigate with power dynamics here? Because it's default masculine and we are talking about women's health materials. And how do we ensure inclusivity? So Jessie has already hint a bit on reviewing the documents and, like community engagement. So community engagement comes in here. In order to make those documents inclusive, we must engage with our communities. So Dr. Lesa Dawson mentioned about this consent form that was shared with us. So I have given you examples about like complex language, use of English words, but accuracy is also important for equitable access to care. In this context, we also see a lot of power dynamics. For example, the team who sent this for translation and didn't review it, or a translator who thought that they could do anything and nobody is going to review their work. So those kind of things must be considered in terms of navigating those power dynamics. Then giving you an idea of what is the range of problem. So the consent form, lot of mistakes, errors in the writing, but we have also noted some examples from our community. For example, this is one of the community events about dementia. This is their advertisement in Punjabi language. Although a lot of things are correct, it is fine. But then there were two words that I really felt were culturally inappropriate. For example, they use the word katna for event. In Punjabi language, katna is not a positive event. It is an accident, mishappening. It is something of that nature. So for an event about dementia, using that term is culturally inappropriate. And then they refer to stigma as kalank. Kalank is also a very negative term, using as a black spot on somebody's name, something very negative. Are they really destigmatizing? Like, what is the purpose of, this thing? Or they kind of enhances stigma by using these terminology. So I was really interested in where these terms came from. So again, Google Translate. So I put in stigma in Google Translate and it gave me the same word kalank, and I put event, it gave me katna. So when translators are using AI, they need to be very, very careful, because AI is not culturally or gender sensitive. They are giving us, terminology that's, that they think is fine, but it's culturally not appropriate. Another example about language accessibility. So again, thinking about our target population, rural immigrant Punjabi women who are reading the materials. This may be for general audience, but I'm thinking about Punjabi population in general. So again, a lot of use of Punjabi words, words that are used. Some of them are really difficult. Some of them, at least Jessie and I have never heard. So some really new words that we came across. So these translations are meant for educated Punjabi reading audience who can probably also read English. So there is a need for simplification. For example, we specifically noted example of sex, gender, and sexual orientation. This must be something in English, original document, and then they have translated sex as sex because they couldn't find another word. Gender as a ling. So ling word is used for both sex and gender interchangeably in Punjabi language. So somebody who is a Punjabi language reader then gets confused between these words. So how is sex different from ling, which they have used for gender, or even for sexual orientation? So these are the terms that need some sort of explanation and how they are used in context of this particular translated material. Another example about language accessibility. So Dr. Lesa Dawson often gives this example of how breast cancer is translated to Punjabi, and a word chhati is used, which means chest and not breast. So in Punjabi translated materials where they really want to refer to breast and not chest, and they are using the word chest, which is used a lot in Punjabi, in population. But then they also need to give some explanation that although they are using this term, which is commonly used, but they are referring to breast. So there is no explanation for that. In other materials, they have been using the word breast in English itself. So this is also confusing. So are these materials different from the other one where they're using the term breast itself? Again, some really new words that we haven't come across. In this particular document, they have also assigned wrong gender to cancer. So that also kind of like, as a Punjabi reader, I'm like, is it work of AI or some human has done it? So it's really hard to, understand these materials. So everything in blue arrow is an English word that has been translated and written as it is in Punjabi. For example, words like tissue technologist, radiologist, radiation technologist, words like pressure. So are we really able to distinguish between these terms like technologist, radiologist, radiation technologist? Like, what are these terms like? So adding some explanations, some definitions, additional words could be useful for translations to understand. So we recommend a stepwise process. Jessie has already talked about like how our framework focuses and motivates us to ask relevant questions in the beginning. So I'll talk a little bit about why asking these questions is important. Step 2 is looking at translation as an engaged process. So this is not something that we have contracted a translator and we get the final draft. So it is more, there are more steps to it. It is more of an engaged process. And the last one is review of the translated material. So all the examples that we presented in this presentation, we learned that there are many errors, there are many culturally inappropriate words added, there are many English words added, complex terminology. What if we we include our patient partners, community partners into the process, and we get better words and translation out of it? So why asking relevant questions is important? Because that places some sort of responsibility for this translator, that they are producing something which will be reviewed and team is interested in getting the best work. So it is very important to ensure and talk about translators' understanding of target population, who they are producing the materials for, their understanding of topic. So research notes that many topics such as chemotherapy, they're often very oversimplified by translators. In Punjabi educational materials, their understanding of terminology about women's health and their comfort with that terminology is also very important. As we have already noted, consistency is an issue. So consistency is very important. reviewing is existing materials from the same organization. Like like cervix was an example. What if the second translator, whoever did it later, got an opportunity to review some of the materials around cervix from the same organization to ensure that there is consistency in the language. Translators' fluency and training is very important. A lot of time we come across individuals who say, I'm a fluent Punjabi speaker, I can do translation work. But translation is something that has to be done by an expert. So these are things that can't be overlooked, because we are not looking for fluent speakers, but we are looking for people who can read and write and, like have that kind of fluency in the language as well. Their use of AI. So we are coming across a lot of work that was sent to Punjabi translators, but we know that that is a work of AI. So making sure that we have certain discussion on to what extent AI will be used in that particular work, their approach to ensure cultural and gender sensitivity, their understanding that Punjabi language is gendered and it functions within binary. So how will they make sure that translated materials are inclusive? Especially we noted the terms like sex, gender, sexual orientation, transgender, gender diverse. They are used as it is. So they don't really translate those words, but they just write it in Punjabi. So navigating that language binary is also, how will you do it? Especially in context of women's health materials, their openness to review of their work. So this is very important. And we have noted in our past experience that many translators are not open to review of their work. So it is very important to have that conversation in the beginning if we are involving patient and community partners into the process. Because there are many, power dynamics within many translators think that they are qualified enough to translate. So nobody else has that business to kind of look at their work. So having these conversations at the beginning is very important to enhance quality of translated work. And then in our framework, we also, focus on having a translator reflection guide so that translators also get an opportunity to reflect on their translation process. For example, did they really understood the aims of translation, their understanding of target population? Is there anything that made them uncomfortable as they were doing this work? What resolution strategies did they adopt? What words and phrases, they kind of choose instead of certain specific words or phrases? Their decision on culturally and gender appropriate word choices and alternatives, as I have already mentioned, their reflection on the process. So was it word to word, meaning based? So those kind of experiences must be reflected by the translators. And also they must have opportunities for discussion. For example, I'm the translator and there is a word that I don't understand. So there should be an opportunity that I, go back to the team and ask, can you explain a little bit more about this word? And I don't want to depend on Google to kind of search what this word is. So how do you want me to, present this information? And also including patient and community partners. And we propose that by doing this, at the end of this step, we will only have first translated draft. And then review of these translated materials. So review with a relevant patient population or community partners. Community engagement is very important in translation process to ensure the quality, accuracy, accessibility, those issues could be addressed by community engagement. Also important to compile the feedback that comes from patient and community partners. How we do that is also very important. Because within Punjabi community, age and gender dynamics could be really significant. For example, I'm a younger person who is leading this conversation, who is leading this group of people who are giving me feedback. So who, my identity, like who is leading this work, who is making final decision of what goes in translation, it must be very transparently communicated to people in the group that, okay, Reetinder will be leading this conversation because Reetinder has these kind of educational qualifications or skills, and open to conversation, open to listening, and, having that kind of conversation with the group. Again, important to inform translators that their work is open to review. So I noted one example where translator was not clear about if their work will be open to review. So when they joined that meeting, they were very uncomfortable with the idea that some younger people are leading the conversation and this older person is not being heard. So those kind of dynamics could be addressed by having this conversation early on. And with this, we will have final draft of our translation, which is, and we are able to address most of the problems that we have highlighted in existing materials. Now I'll hand over to Jessie again.
Perfect. Thanks so much, Reetinder. Just want to briefly, if you could go back to the slide that you were just on, just really quickly review again. So Reetinder did a great summary of the work. Just want to highlight how Punjabi language sentences are structured is completely different than English. And what we're finding currently is that literal translation seems to be the way that materials are created. This actually doesn't land. Where we're really highlighting is that complexity, consistency, culturally competent, clear, plain language, and community engaged translated materials are necessary. And she highlighted the stepwise process. This is where we are trying to impart the accountability on the translators so that they are asking relevant questions to understand the audience, the topic, and terminology, and they are questioning the fluency in the right script and their approach to translation with cultural and gender sensitivity. We're also really highlighting the translation needs to be an engaged process where they are literally creating or utilizing the reflection guide to consider their understanding, comfort, and decision-making. And they're encouraged to reflect on where they feel challenged and uncomfortable about terms, concepts, and how they are discovering and transcribing the materials and seeking input from the community partners. And then without community and consultation and co-creation, good, relevant, culturally competent translation materials are not truly possible. And we really are inviting researchers to understand the enormous opportunity to gather feedback from the target audience, considering the age and gender dynamics, and that the final product then truly is a true collaboration shaped by the voices and the experiences of Punjabi women themselves. Next slide, please. Thank you. So Kaur Collective has been around for the last 10 years, and really we are focusing on women's health as a very strong third pillar of the work that we're doing. And as the slide really describes, this is where our vision becomes reality. We're blending narrative medicine, culturally attuned translation, and storytelling to empower Punjabi and South Asian women overall. So we have a podcast, we create oral histories and community-driven health materials so that we create space where women can reclaim their bodies and voices. Our work is grounded in Sikhi values and led by Punjabi women for Punjabi women. Every story we tell, every resource we create is a step toward visibility, voice, and self-empowerment. And what has been really an honor is how on a global platform, leading publications like Vogue, Harper's Bazaar, and Allure, and so many more have been bringing visibility to South Asian women's stories and now health experiences to amplify these voices on a global platform. Next slide, please. So our next steps, as outlined, are ambitious and clear. We are looking to secure funding to revise and continue the work with the framework and develop a comprehensive women's health dictionary, along with many other aspects that we've mentioned today. We would like to continue to deepen our community engagement, create the anatomy comprehension exercises, feedback sessions, and real conversations to finalize the framework. We are looking to build relationships with health organizations to ensure high quality Punjabi translation for existing and new materials is possible and viable, and provide consulting on research and community engagement initiatives. Really, though, this is about more than translation. It's about shifting the balance of power, making sure Punjabi women are never invisible again. Next slide, I think. I guess I spoke a little too early there. So the importance of this work in the larger context. This work is, again, we've said it many times, it's not just about language. It's about making the invisible visible. It's about giving Punjabi women the language and the power to ask questions, make decisions, and advocate for themselves. And it's really shifting the narrative from silence and shame to voice and agency. And it's building a future where every Punjabi woman can see herself reflected in the health system and can take control of her own health journey. We really value and thank you all for joining us today. Our information to contact us is on this slide here. And we really want to just reinforce this is how we make health equity real, and this is how we end invisibility. Thank you. And we invite any questions if anyone has questions.
Amazing. Thank you so much. Questions, you can put your hand up or pop them in the chat, and I'm happy to read them out. Lori, go ahead.
Amazing, really important work, amazing presentation. Thank you so much for this. And I mean, there's so much implication of the work that you're doing, not just for Punjabi women, but for other ethnocultural groups, etc. One of the questions I had was specifically about sexual health. And so in my own clinical work, where I also work quite a bit with South Asian women, the topic of taboo around cervical cancer as inappropriately being associated with a sexually transmitted infection, and the implications of that for unmarried women, for unpartnered women, etc. And I'm just wondering how that showed up in your work. Did it show up in how the translators maybe altered how they talked about cervical cancer screening or other kinds of screening? Yeah, really curious to hear how you manage that in the translation materials.
Thank you for your question, Laurie. So I use cervical, cervix as an example. So definitely, the language around cervix and trying to kind of make it dilute the concept a bit, definitely there. And I also worked as consultant on different projects, not on this specific topic, but other topics, where translator try to change the word so that it really is fine for their Punjabi, reading audience, thinking, oh, women will be reading this, so I'll use this word. So I feel that it is there. So some sort of training and open communication with the translators is really important. So that's how we are proposing that asking some relevant questions, that openness to communication is important. Training of translators is also important, because I do a lot of translation work, but I also feel that, getting to know topic bit more better, and, understanding target, population and importance of this important, topic, getting some stats around it, like why is it even important for, my community that I'm working for, is really important. And there is definite tendency, thinking about gender dynamics, even within our homes, when it is about interpretation and not translation. Families try to dilute some information. She's an older woman, she's a woman, I'm the protector, I'm the, father or husband. So there is that thing that's definitely there for somebody, who needs an interpreter. Even for translators, we need to be careful. So I think training of translators is important, telling them that this is, this is our target population, and this is why this topic is important.
Love that answer. Love the question. I will add in a little bit more. So shame and stigma surfaces in all aspects of South Asian women, particularly Punjabi women's lives. But what we're finding is when we are doing these storytelling initiatives, the shame kind of dispels if there is a trust environment, and a lot of these problems are surfacing, and health outcomes are diminishing because women are shrouded with the shame of not being able to voice these concerns. So what we, along with what Reetinder is saying, is really holding the accountability with the translator, providing that education, but also we understand that within our community, our women do not even know our own body parts. So really creating that anatomy workshop, literally creating a dictionary so there is baseline words so that women can have the language to create the empowerment that they need, that we are envisioning kind of having bodies, images on worksheets where they are circling what the body parts are and then being able to understand the body parts that connect with them. Because if we don't know even where our body parts exist, then how are we supposed to really voice to physicians and other health practitioners where we are having pain and we're having discomfort? So thank you again for that question.
Dr. Garg?
Thank you very much, and thank you. I just want to start with, I don't have a question, but a very short comment. I'm so happy and so delighted that this round is taking place, and I just want to thank everyone, and especially Lesa and Lori and Research Institute and my two colleagues, Reetinder and Jessie, to really make this very critical area mainstream. So what we are doing, and you should be so proud of today, for the best of my knowledge, first time a established group is talking about a topic which has been totally missing from medical parlance. I'm a medical doctor, for some of you who don't know, have been in practice for 50 years, and now I am very passionate about filling that gap. And the gap is in the broader context, and Jessie has articulated so well, the gap is how to engage, how to educate, and how to empower the community and the individuals. And obviously gender, women, and the power politics and the language plays a huge role. So this is a very critical topic, but the empowerment, which has come several times, is very critical. And I just want to finish by saying the task my two colleagues are undertaking is very complex and very little is available. So any help we can get in terms of funding, policy change, which will be very good. I just picked up a little book, dictionary, and I was looking for some words, and words are missing. So just so people understand, the language is so complex and the words from English are just non-existent. The words which are in Hindi or Sanskrit or in Punjabi cannot be translated into English, and the English words cannot be translated. So as Jessie pointed out, the context, the space, and the time becomes very critical. So once again, thank you very much. This is a start, and we look forward further to collaborate through our organization, and we have done a lot of work. And thanks again, and especially to Lesa, who has taken a great interest. So thank you, Lesa, and women's health will be better and stronger because of your efforts. So thank you.
Kristen, you want to ask your question?
Yeah, and thank you so much. That was a really helpful presentation for people kind of dipping their toe in this area and trying to understand how to do this work better. So thank you so much. And I feel like I'm taking it from like such great global perspective now down to like pragmatic things like, so how do we support you in your work to connect with some of the things we're already trying to do so that we're like either helping to support the work that you're doing, and getting involved with the resources, but not overburdening you with like, hey, we have a project, we want translation too. So just trying to understand how best to connect with either your organization or others to not overburden, but make sure that we're kind of engaging correctly. Yeah.
Love that. Thank you so much for that question and for the opportunity. So, while I know this is an academic research space, I will say we are open for business from a consulting for a cost recovery basis, as we alluded to, and we know that there is urgent need. We also realize that if we are practically applying our framework and going through the process, it will actually support our research even more and more. So we are building actively partnerships. We have one, almost two secured, and we are looking for others. And Reetinder and I are available, but we also have a team of other individuals on standby to support as this topic and work kind of keeps moving forward. So we look forward to connecting with you afterwards.
Thank you. Thank you so much.
Any lingering questions from the audience? Feel free to pop them in the chat too.
If I could just weigh in at the very end. Thanks, Catherine. Jessie and Reetinder, you guys continue to impress me every time. Every meeting, every interaction, I just continue to learn from you both. And I'm just so grateful to you. And I actually truly believe that this sort of work is going to be at the heart of where we want to all be with equity and care delivery and women's health. So thank you very much.
Thank you so much. Thank you for championing us and providing us with these opportunities. We really appreciate you, Dr. Dawson.
Thank you.
I think on that note, I think Lesa summarized it beautifully. What an amazing presentation. You've given everyone so much to think about, especially the use of AI in translation and being very cautious about that, or working with the appropriate partners. So thank you. We will be sure to pass your information along to any teams that are looking to partner for this type of work. But really, really value your sharing your knowledge and expertise with our group today. So thank you.
Thank you
so much.
Everybody have a great Friday.
Happy long weekend.
Happy long weekend. Yeah.